Greater Community Health. We are absent a fearless facilitator this morning. We let Patrick Jones off the hook since the majority of the meeting will be facilitated by Sam Wardell, our Director of Practice Transportation. First of all, I would like to thank GCACH. They have really stepped up to their plate and provided just a wonderful buffet of goodies for us to eat and enjoy this morning. So thank you to GCACH. Also, just remember to have everybody put their names in the chat box. So if you want to get credit for your organization as participation in the learning collaborative, you can make sure that you do that. Otherwise, we're really looking forward to today's conversation with our EMS folks. Greater Columbia has viewed the EMS folks as really critical to our implementation and transformation efforts. There's a lot of things that community care medicine can do to fill in the gap for care, especially in our rural areas. And we were so blessed that when we did our letters of interest, we had, I think, 11 EMS agencies. I think that was times writing everybody, make sure you send your letters of interest. That there was a lot of interest in our waiver project, and there has been legislation passed that would allow for some reimbursement. So I don't know that that legislation is being cited yet. So I think we'll hear more about that later. So we are going to have a full agenda today. If you need to get up, please don't get up. I don't think that we have a scheduled break. Is there anything else? We're not going to do our GCACH report because we don't have a lot of time. We wanted to dedicate that time to the EMS folks, and then we're going to have a short presentation by Wes Leslie, so it kind of grounds us as to why is this so important. I think you'll hear from Wes as well as the others is that EMS as a first responder sometimes visits our patients many, many times before they even get to the hospital. And the problem that they're having in our community is that because we have so many fire districts, they might be getting calls from different fire districts. So it's possible that a Kennewick Fire District might not know that a Richmond Fire District is actually responded to the call. So we're trying to accommodate that. We're trying to find ways so that the EMS can communicate together. So we're exploring some use of technology for that matter. But it's a complicated thing across the state, and it's a costly endeavor for our EMS services when they're responding multiple times to a patient that could actually receive better care with other social services. So with that, is there anything else that I'm missing, Lauren? Oh, and make sure that you sign in the chat box, sign in on the sign-in sheets out there. And otherwise, I think, is Wes, are you up first for the, essentially? Oh, okay, you will then come up. Thank you, Sam. You're welcome.
Good morning, everyone. I would like to read my introduction. There's a lot of information, historical data that I'd like to share with you just to make sure that we bear with me while I read through this. Fire Service-Based EMS, the Federal EMS Act of 1973 defined as EMS system as an entity that provides for the arrangement of personnel, facilities, and equipment for the effective and coordinated delivery of healthcare services under emergency conditions and an appropriate geographic area. Therefore, pre-hospital 911 emergency response and support key function of each community and fire service as well. Today, essentially every firefighter receives emergency medical training, and the fire service provides the majority of medical services during emergencies that occur outside the hospital. Today, the community-based fire station, when it's ready, availability of personnel 24 hours a day, coupled with the unique nature of medicine outside the hospital. In configuration of the emergency medical services, the fire service can be configured in many ways, in which you'll hear today. In the field of emergency medical services, there are different levels of certifications for provider of care. Emergency medical technicians, EMTs, are the most common type of providers in all of EMS. They are an entry-level patient care provider followed by EMT intermediaries. In some states, and then a paramedic. EMTs are sometimes referred to as the EMT basics or the EMT. However, do not be fooled by the term entry level. EMTs learn the essential skills to help in life-threatening situations, and their education and foundation for all levels of providers. Both EMTs and paramedics have the knowledge and skills to transport patients and provide them with emergency The biggest difference between them is the amount of education they receive and what they're allowed to do, i.e. the physical care, right? Training for EMT and paramedics is very different. EMTs usually complete a course that is about 120 to 150 hours in length. EMT and paramedic courses consist of lectures, hands-on field training, clinical and or field internships. EMTs are educated in many skills, including CPR, giving patients oxygen, administering glucose for diabetics, and helping others with treatment for asthma attacks or allergic reactions. Paramedics, their courses between 1,200 and 1,800 hours. Paramedics are advanced providers of emergency medical care and are highly educated in topics such as anatomy and physiology, cardiology, medications, and medical procedures. The eligibility requirements and prerequisites for EMT and paramedic courses may vary from school to school. The biggest difference in duties between firefighters and EMTs beyond firefighting is that EMTs, with the appropriate level of training, can administer emergency medical treatment, whereas a paramedic, for example, can intubate a patient and authorize the use of certain medications. The concept of community paramedicine, also called mobile integrated healthcare, is taking EMS by storm. Numerous articles have been published and considerable discussion has occurred regarding community paramedicine. But what it is and why is it occurring? Some thought it was a strategy to increase EMS utilization by targeting frequent users. Other programs worked with local hospitals in an effort to decrease admission of high-risk patients, such as those with congestive heart failure, chronic obstructive pulmonary disease, and similar diseases. There have been other iterations of community paramedicine that have included primary care, home health care, and other non-traditional EMS roles. Despite this, the definition of community paramedicine remains nebulous. The concept of using paramedics as a non-traditional primary care role is not new. Between 1995 and 2000, a special project called the Red River Project used 3 specially trained paramedics to provide primary care for this region after physician recruitment failed. Ultimately, the Red River Project failed for several reasons. One of the biggest problems was the constant turnover of personnel. In addition, it was generally held that the education program was inadequate to provide the necessary care. The most fundamental flaw was the fact that the system was never integrated with the local medical community. Reduction of unnecessary transport and readmission. Every EMS system, regardless of size, has people who use the same system unnecessarily. These people are often referred to as frequent flyers, loyal customers, or super users. These patients do not use tax resources and can indeed take needed resources away from, or at least they do use tax resources, they can indeed take needed resources away from their other patients who actually need the EMS service. Numerous studies have been conducted to identify these super users. Reduction of readmission of chronically ill patients is another area that we work with the EMS. The readmission of patients with chronic illnesses to the hospital is costly. In general, it can thought to be avoidable. The Centers for Medicaid Services, CMS, now penalizes hospitals for readmission of high-risk patients within 30 days. Over the last several years, the amount of these penalties have increased, thus prompting hospitals to look for strategies to reduce the remission of these high-risk patients. Certainly, the EMS system may garner some revenue from a community paramedicine program, but the amounts are not significant. But in the overall scheme of things, hospitals are looking for the most economical way to protect their bottom line, and paramedics are the cheapest for their able healthcare professionals. EMS in the primary care setting, U.S. healthcare system is broken, and we all work with this system, right? And like other developed countries, there is limited primary care access in the United States. This is especially true in rural communities and poorer areas. The current reimbursement scheme for U.S. physicians actually drives physicians away from primary care. Specialties that are highly procedurally based, cardiology, gastroenterology, for example, pay considerably more than primary care specialties. This brings us back to the initial statement. The U.S. healthcare system is broken. So in order for us to fill the gaps in primary care, we are turning to paramedics, who are among the lowest paid medical professionals in the country. We are asking them to step outside their traditional emergency role and begin providing primary care. In addition, these paramedics are generally not recognized as approved providers for insurance companies and CMS when outside their traditional role. There is no easy way for them to obtain the reimbursement. At this time, I'd like to bring Wes up to go ahead and introduce.
Haley Middleton, I'll be Big Health Association. Kenny Bell, with Ideal Balance.
Eric Clark, First Name
Johnson.
Sierra Foster, Australia Health.
Jenny Krieger, psychotherapist.
I'm Susan Campbell. I teach at CUC and volunteer at the UNICEF Foundation.
Alana Olaitero, Chapel.
Raquel Volunteer Health.
Ruben Peralta, Greater Columbia, GCACH.
Rachel Gantz, Greater Columbia ACH. Becky Wolf, Greater Columbia ACH.
Matthew Sanchez, Greater Columbia, GCACH.
Diane Taylor, Greater Columbia ACH.
Angela Chavez, Community Health Plan, Washington.
Kendra Palmer, Catholic Charities.
Dr. Gonzalez, GCACH.
Barbara V. Gordon Health.
Gina Otis, Lord Health.
Kevin Taylor, Lord's Health.
Jocelyn Pedrosa, Yakima Neighborhood Health.
Michelle Sullivan, Yakima Neighborhood Health. Lisa Hefner, Yakima Neighborhood Health. Diane Campbell, Yakima Neighborhood Health.
Wilson will be Catholic. John Christensen, individual.
Christina Rodriguez, Community Health.
This feels weird. I'm
Not in control.
No, hi, I'm Sherry Snow White from America.
Eric Nelson, Kettle Fire. James Hempstead, Richland Fire. Stein First Bank, Richland Fire. Ben Shearer, Pasco Fire.
Becky Gross, Consistent Care. Sandra Suarez, Yakima Valley Pharmacy Fire.
Morgan Linder, Willow
Good morning. I'm Cameron Flynn from Spokane Neighborhood Action Partners. Tracy Brennan with Catholic Clinic Pasco Primary Care.
Tyler Platt, Ross Memorial Health.
Carly Green, Cross Memorial Health. Michelle Burley, Pasco Fire Department.
Bill Whalen, Benton County Fire Station number 4. Paul Carlisle, Benton County Fire Station number 4.
Mandy Olson, Kittitas Valley Healthcare.
Lauren Johnson, GCACH.
Ashley Fernandez, GCACH.
You've met Carol and Sam, and I'm Wes Lucky. I'm the Deputy Director for the Greater Columbia. We're going to talk a little bit about data this morning. Oh, I'm sorry. And for people who are on the phone, can you please introduce yourselves? If you're currently on mute, would you please unmute yourselves and introduce yourselves?
Kevin Martin, Kittitas Valley.
Judy Miller, Columbia County Health System.
Minnie Smith, Columbia County Health System.
Everett
People for People.
Everett Maroon, Blue Mountain Heart to Heart.
Jean Merle, Family Learning Center.
Chris
Brian
Dillon,
Lance.
Catholic Charities.
Chris from Catholic Charities, Christian.
Yeah, there was another name.
Sue
There
Jenner,
was somebody else.
Memorial Health.
Keith Monowski, Pacific Northwest University Health Sciences.
Adam Davis. PJ Osborne and Kim Nygreen from Police Medical. Adam Davis from Puget Sound Fire and Health Commons Project.
Siobhan Brown, Community Health Plan of Washington.
Marissa Engels, Coordinated Care.
Brian Lance, Virginia Mason Memorial.
Ryan Lance. Is there anybody else on the phone who hasn't introduced themselves?
Marcia Baden, Garfield County Hospital.
I'm sorry, there was two people speaking at once.
Marcia Baden, Garfield County Hospital.
Allie Young from District 4, West Richland.
District 4, West Richland.
Is there anybody else? Okay.
Sanders, Pullman Family Medicine.
Who is that from Pullman Family Medicine?
Kelly Sanders.
Thanks, Kelly.
Is it on? Oh, there it is.
Okay, so we're going to talk a little bit about data today. I'm going to run through a brief presentation. We're going to look at ED visits here in the Greater Columbia. Some of the sources that we used for this come from DSHS's Research and Data Analysis Division, also known as RDA, and Healthcare Authority's Analytic Research and Measurement Division, that's also called the ARM. So the primary metric that we're going to focus on are emergency department visits per 1,000 member months. I'll talk a little bit about what that metric means. The metric description is a count of ED utilization among Medicare beneficiaries within a particular time period. The data source comes from provider one and the claims and encounter information that rolls into that system. The direction of quality improvement, in other words, we want to see that number go down. The denominator here are all Medicaid beneficiaries, excluding people who are dual eligible, which means they have both Medicare and Medicaid, individuals who might be under hospice care, as well as Medicaid beneficiaries who have been in the system for less than 7 months within the reporting time period. The numerator here is just simply a count of emergency department visits. So I created this diagram, and I'm not going to belabor this too long, but this just talks about how the data is counted. So in this example, there are 7 members, member A, B, C, D, E, F, G, and those columns represent the calendar of January, February through December, and the blue boxes represent that beneficiary enrollment within the Medicaid system. So you can see for member A, they were in the system all year. Member B was in the system until August, and then they dropped off. The reason why I bring this up is, first of all, to talk about member C, who has 6 months of beneficiary status, is not counted here, because again, you have to be in the system 7 months or more to be counted. Member G, who's only in the system for 5 months, is also not counted. Everybody else here would be rolled up into the visit count. Now, the reason why they do not use simply members as the denominator is because, for example, member C, or excuse me, member B, who drops off in August, but that individual may have had utilization in the last 4 months of the year. So to assume that they don't would undercount visits. So the way that the denominator here, and I know this is a little complicated, you can talk to me after the presentation, but the way the denominator here is counted is for those individuals who are eligible, they simply count the number of blue boxes, which is their month of eligibility. That's the denominator divided by 1,000. And the numerator is simply the total number of ED visits. And so that calculation at the bottom, ED visits per 1,000 member months equals just that. Again, a little complicated. If you want to talk to me afterwards, please do so. Of course, everybody knows this. This is our famous Christmas tree chart. We've highlighted here the 2 outpatient ED visit measures. As you can see, those 4 colored boxes that go up horizontally represent our 4 current project areas. So ED visits is counted among all 4 projects that we're undertaking. The only other measure that does that is inpatient hospital utilization. Again, this is a message from Healthcare Authority that mitigating inappropriate institutional utilization is a priority for them and for us. These are some maps that I did in an analysis going back to 2017, if you were part of that discussion. This comes from RDA, from DSHS. These particular maps map out for Medicaid children and for Medicaid expansion adults. These are the 2 biggest groups within Medicaid. populations for 2016. The darker the region, the higher the utilization. And as you can see for the Greater Columbia ACH, we have the highest ED utilization among all the ACHs within the state of Washington. And we don't think that this is something new. This has been going on for a while. You may have a hard time seeing the numbers in this table. This comes from the ARM data dashboard that was just recently updated with 2018 data. The only column that we're going to talk about today is that first column that says number of ED visits. So these are the number of ED visits that excludes dual eligibles within the 2018 reporting year. So, and those are only ED visits for members residing within our service area. So the actual number of ED visits at Virginia Mason Memorial would have actually been greater than 40,098 if we included Medicaid members who were coming in from outside the region. That said, Virginia Mason and Cadillac Regional Medical Center had the highest ED utilization among any hospital in the state of Washington. That includes Harborview, Swedish, Sacred Heart, and any other hospital. Those were hospitals number 1 and number 2 in terms of utilization. I also want to point something else out here. If you take the number of ED visits and you divide it by the number of unique members who received ED visits, the ratio is about 1.1. So this just tells us, I think a lot of people think that Medicaid members go back to the ED again and again and again and again. And the reality is that the vast majority of Medicaid members only go to the emergency department one time. There is a small group, and they've been called MVPs or frequent flyers, who do go back over and over and over again. But for the most part, the vast majority only have one ED visit within a calendar year.
There was a gentleman who had a question. I was kind of thinking the same thing about uninsured, like Kittitas, they're not unaccounted for.
Kevin Martin said, can you speak to how uninsured rates impact this data? Kittitas leaves the state in uninsured.
So I'm not sure I can answer that. These numbers relate only to Medicaid visits. So let me think about that for just a second. You know, for the most part, because of the ACA expansion, there were literally hundreds of thousands of individuals in the state of Washington who previously were not eligible for health insurance who are now eligible. So the people who are uninsured typically fall into two broad categories. First of all, they're ineligible because of their document status. If they're undocumented individuals coming into this country, they would not be eligible as an adult. If they're a pregnant mother or a child under 19 years of age, they would be eligible for medication. Outside of that, they wouldn't be. The other group would be those individuals who elect not to carry health insurance. And they may be eligible for Medicaid, or they might be in an income category that puts them outside of that, of which they should subject to the individual mandate and the penalty tied to that. So I think that group is small. I would have been, I have a good answer. Anybody else?
Our sense up here. Our sense is that the rate is probably, yeah, our sense here is that that number is probably mostly the latter quality, people who refuse to take advantage of Medicaid expansion for ideological reasons.
Thank you.
But I think that underestimates our safety net utilization of the emergency room if we're only counting Medicaid.
Exactly. Exactly. So this is the final slide I'm going to talk about today. Recently, we received our baseline assessment of pay-for performance measures, which, as you know, beginning this year, we're subject to 25% of incentive payments will be based on our performance across that Christmas tree chart that we looked at just a couple slides ago. So we did an analysis where we compared our performance versus the Washington state average. So the Washington state average is that green bar. and the GCACH average is that orange bar for ED visit rates for 1,000 member months. And this is for all age groups that are subject to the pay-for-performance criteria. So the difference between the 51 visit rate and the 68 visit rate is 17 visits per 1,000 member months, which doesn't seem like a big deal. That translates into 41,000 visits per year. That's how far off we are from the state average. If you remember going back to that list of hospitals, that's more than the busiest hospital, their entire Medicaid ED visits in the state of Washington. So doing kind of a rough analysis, I calculated, these are conservative estimates, we multiplied that 41,000 visits by $1,250 to $1,500 per visit, that equals $51 to $61 million of extra spending on ED visits. So really the success of this experiment that we're embarking upon will really be based on our ability to turn back the cost curve. The most direct way of doing that will be through the reduction of inappropriate institutional utilization, if I can be frank. That includes ED visits, inpatient admissions, and readmissions. The high ED visits in this region are complex to understand. There's no homogeneity among the group that goes to the emergency department. And this is an issue that goes back for decades when I was working for an insurance company. But that said, these numbers explain why our primary focus is on this particular area. Does anybody have any questions? John?
I've got a question about your, I think it was the slide right before this one, that showed that Cadillac Regional and Virginia Mason had the greatest ED visits of all the hospitals in the state. And the ratios were 1.1, I think, and 1.11 and 1.12. No, 1.11 and 1.10.
Right.
Which makes me think, well, those two must be performing about the same, because ED visits per unique member,
right,
they're almost exactly the same.
Yeah.
And yet, when you compare in the last slide, it looks like we're doing, we have a lot more.
Right, so we're comparing, and again, pointing out those two hospitals was not meant to be a critical statement against those hospitals. Again, this is a complex issue that affects the population of individuals going into those emergency departments. There is a difference between what was being measured between these two slides, and this particular slide simply measures our performance to the broader statewide average. And again, that's not entirely fair. As we all know, the Greater Columbia is highly rural in nature. Some of our counties are 100% rural. King County, Pierce County, obviously those are very dense metropolitan areas. That said, this phenomenon of high ED utilization has gone on for decades, and it's just simply something we need to address. And we believe we have strategies in place to do that, including about what we're going to talk about here today. Barbara?
Well, we have, I know this data is focused on Medicaid solely.
Yes.
Do we have any data that's broader than that, that includes all the other categories of payers?
So that's a good question. We recently contracted with King County to access what's called the All Payers Claims Database, the APCD. And the APCD includes Medicaid. It'll include Medicare. I don't think it includes Medicare Advantage or and it includes commercial other than self-funded. Self-funded means individuals where the company, the buyer of the healthcare product is actually financing the risk. In any case, it includes a lot more data than just Medicaid clients. We have access to that, and we're working with them to produce some reporting to meet some of our strategic goals. So we can possibly get more information out of them as we go forward. Sure.
There was another question by Everett asking if we have a breakdown of the ED visits by diagnosis.
Actually, we do. If you go back one slide, Lauren, the slide before this where we look at the individual hospitals, if you go on to the Healthcare Washington website and simply type in dashboard at the search line, you'll find the ARM dashboard where this data comes from, and you can go in and break out each hospital utilization by the category of visit. And for the most part, this is not any surprise. Typically, the number one reason for inpatient visits is normal newborns. But that information is available online. It's not proprietary. It's open to the public. Any other questions? Thank you very much.
At this time, I'd like to present today's challenge in an ever-changing EMS environment funding with Eric Nielsen, Kennewick Fire Department. Eric is the EMS officer for the Kennewick Fire Department, where he has served the community since 1995. Starting as a firefighter and progressing through the ranks to fire captain, to his current position overseeing all EMS operations. His current position manages everything from daily logistical operations for primary 911 ambulance responses, CQI, managing supplies, medication, and other assets required to keep the progressive operations of Kennewick Fire Department at peak performance. He is also responsible for numerous other programs, including Respiratory Protection Officer for Fire and EMS Operations Coordinator of OTEP, and ongoing training for all levels of EMS in Benton Franklin County. The regional lead for the Image Trend RMS project for 5 area departments and Information Technology Liaison, KFD, and the City of Kennewick's IT department. He currently serves as the local EMS Council Chair, GMCC Committee Chair, member of the Protocol Committee, and is heavily involved in Alliance Consistent Care and the development of the Community Prepared Medicine program for KFD. In addition to his work at KFD, he coordinated the paramedic school in Columbia Basin College from 2000 to 2012. Through his work at CBC and KFD, he has developed a network of working relationships in the Mid-Columbia that spanning fire chiefs to hospital administrators and EMTs to EMS officers. His vision of what EMS is in the Tri-Cities can be and is always adjusting and growing to account for the ever-changing healthcare industry. Eric is a firm believer that a community paramedicine program that is specifically designed to meet the unique needs of all the cities within the Mid-Columbia, and the next step is providing for safe and secure living environments for all citizens in the Mid-Columbia. Thank you, Eric.
Good morning. As Sam said, my name is Eric. I'm the EMS officer for Kennewick Fire. I really appreciated Sam's intro this morning about EMS and giving that look from, it really dates back into the early 60s, but especially from the 1970s. Something started in those days after we built these broad highways across our country, and people started moving their land yachts from coast to coast, and we started having all these accidents, and that's really where the birth of EMS came from, was all these accidents. She made a very quick reference in there about how EMS was paid for, partly by hospitals. There's another unique fact in there. Do you know who else paid EMS in the early days? Funeral homes. They literally, the ambulance, as they were on their way to the hospital, if the patient was dead before they got there, and old timers in Kennewick tell me that they came down Kennewick Avenue, it was a matter of, the guy driving would turn it right or left. Right was to the hospital, left was to the morgue, right, to the funeral home, and that was funding. And through our history, we have always just kind of, the fire service has been there to do or to pick up what the rest of society has been ill-equipped to, and we're fine with that. Please do not misunderstand anything I'm about to say. We are happy to serve our communities in any way that we possibly can, but it has left us feeling like an island. Okay, we're an island that you send whatever your problems are. Okay, and we have a nice island. Don't get me wrong, it's beautiful. Maybe not quite that beautiful, but it's beautiful. Okay, and on that island, we take care of a lot of things. But because really the focus of this isn't about all the great things, I have to talk about some of the things that aren't good. From the federal level on down, And it starts back in the 1970s when the federal government provided all this money to states and organizations to build their EMS organizations. Over time, it's just like every other federal program you know, right? Eventually, it wanes with money and it gets put down on the state level and eventually down to the local level and then eventually down to the level of EMS or fire. And I'll give you an example of that. Well, let me rephrase that. So that's, we're no different, okay? The same thing has happened in EMS and fire as is in many other things. But just like we kind of get forgotten about from a funding perspective, we get forgotten about in other areas. And I'll give you an example. Narcotics. Okay, now I'm not talking about the opioid crisis. I'm talking about the management of Schedule II drugs in the EMS world. When you read the federal statutes, you will barely find any, if and probably not, I haven't found it yet, any specific reference to how narcotics should be managed on an ambulance. So you have the DEA trying to manage these rules that they have really applied for hospitals, and now EMS is left to try to manage it that way. And it's almost undoable to do it legally, okay? Is this recorded? No. So anyway, so those are some of the challenges that we come up against. So I really do feel like we are an island, and we are an island that at times we bring people to the mainland, right? It's called the emergency room, okay? And or sometimes we get called to take them from the mainland back to wherever their island is, right? And we do that, and we're happy to do that. So which is why I was so grateful, and I do appreciate Stein. Stein was relentless to all of us other EMS agencies. Guys, get your letters into GCACH. Guys, and you heard all the things that I do, and I'm not special. Stein does all that work. Michelle and Ben do all that work at Pasco. Paul does all that work at Ben. For every single one of us that sits in one of these positions, we wear like 20 hats, right? Because we don't have a hospital infrastructure to manage all these different projects. And Chief Whalen will tell me, shut up, you have it easy, you're with a city, you have 100 people, I have 10, or less. I'm sure he'll tell me he's doing it all himself, but anyway. But I have this vision that we don't have to be an island like that we could be an island that is actually really connected, okay? And maybe the whole thing looks like one giant chain of islands, but that's my vision. And every time I talk with Wes, or I talk with Sam, or everybody at GCACH, everybody gets it. We could have this chain of network organizations that, yes, we all have our own individual islands. At times we all feel like alone and nobody understands us, okay, but we could be integrated. And one of the biggest ways that we can be integrated, of course, is with information. But I wasn't asked to speak about information flow. I was asked to speak about funding. So let me just, before I go too much further, let me take you to a couple more quick points. The fire service, we of course feel like this is what we've had crammed down our throats from day one, right? Just do more with less, okay, and everything's going to be fine. Well, eventually there comes a point where we can't do anymore, okay? And while we want and we see the vision of how we have to, we really don't feel like we have a choice. We have to become integrated with the rest of the healthcare industry if we're going to reduce these calls that Wes is referring to, specifically in the Medicaid population, of overutilization of the ED. But one of the data points that you're not seeing there is, what about overutilization of EMS? Because not every patient that we go to goes to the emergency department, but yet that still costs us money. Even if it just costs us diesel and it costs us manpower to go there, okay? What about the cost of a service now not available for another citizen because we were over here gladly helping Granny up off the floor, okay? Or getting them a glass of water. These are true stories. They aren't rare. The things that we get called to do when somebody feels like they don't have another choice. So that's left us where, okay, we're doing as much as we can with as little as we have. And one of those other things, besides time, besides diesel, is funding. So I gave you guys a handout. I hope the people online also have access to those handouts. I want to refer to this, the first page of this one, and I don't actually have it on the slide for you. Or do you? Okay. Or I can just talk through it. Either way, it works. I'll give you a quick. This is a quick global view of how EMS is funded. I've broken it down into municipalities, county agencies, and private organizations. And if I've got some misinformation in here from my partners, I didn't have time to validate it with them, but I'm pretty sure this is how it is. I'm sure they'll tell me later. So this is a quick snapshot of the City of Kennewick Medical Services budget. This is not the entire fire department budget. This is just medical services. $26.6 million. That is on a biennium budget. That's not an annual budget, so divide that by 2. 34% of the medical services budget is covered by a utility tax. Okay. 19% of it is for billing for services. Okay. How many of your organizations could survive if you only got 19% of your budget paid for out of billing for services? Okay, and 38% of it is subsidized by the general fund. Right now, obviously there's the utility tax, which when you pay those tax dollars, you're paying for ambulance coverage in your in the city of Kennewick anyway, and Richland and Pasco are very similar. But the rest of it has to be subsidized by the general fund in order for it to be liquid. So many of us in the region have recently had to do cost of service studies, some of them because we were trying to increase our utility tax, and the other reason why we had to do them was for GEMP, which I'm going to talk about in a few minutes. In that cost of service study, we established that in the city of Kennewick, a single ambulance transport costs $2,083 to accomplish that transport. Now, what you have to realize is that there's a big mathematical equation that's taking in everything from the lights turning on to the area where the individual sleeps if we work 24-hour shifts, or the footprint of the ambulance and the truck bay, plus the ambulance, plus the diesel, plus the tires, plus the maintenance, all the things that go with that. All of that rolls into what that cost of service is. Our maximum Medicaid reimbursable amount is $115.34 plus $5.08 a loaded mile. Okay, so that is why 19% of our budget is covered by bills for service. I forgot to add in here the exact percentage of Medicaid patients that we typically transport, but when you take into all of Apple Healthcare, the number is escaping me at this moment. If somebody else in the room remembers theirs, I'm sure ours is very close. It's between 30 and 40%, right, Paul? Is that right? Medicaid, the number of Medicaid patients in a month. I want to say ours is close to. We're sitting about 23%. You're at 23. Maybe we're closer to 30. I don't know. We're somewhere in that ballpark there, and we're all very similar in the area. Pasco might even be a little bit higher. I'm not sure. So anyway, one of the things that's provided us some relief, you can slide down there just a little bit. Oh, let me back up. Let me just talk real quick about the challenges. Obviously, Medicare and Medicaid don't cover our cost of service. Okay. Another big thing that we're hindered by is that we cannot bill for non-transport services. Now, there is one caveat to that. Okay. Medicare specifically does allow for some non-transport services. I believe Pasco currently is chasing those down. When we did the cost-benefit analysis, the amount of hours that it takes to actually accomplish that and for what you get back, we opted not to do that. But again, we could, but we don't. So the other issue that we have is, unlike an ED or a physician or something like that, where you can itemize your billing, we can't itemize. Okay, it is flat rate based on the primary diagnosis code. All right. The problem with that is some of our most expensive calls are for some of our most sick patients, and some of our most sick patients are Medicare and Medicaid, right? I mean, the private insurances might pay a little bit better, but they love to follow the Medicaid and Medicare rules as well. We can't idolize for that. So, and then the other difficulty with that is that if you take a cardiac arrest event in today's medicine, we don't transport people if we can't get a heartbeat back on the scene. And the evidence is very clear that if you don't get them back on the scene, you're not going to get them back. So we don't transport them, but yet we dump a lot of resources into that patient. And again, not complaining here. Please don't misunderstand anything that I'm saying as a complaint. It's just the state of today's healthcare industry. So if you can scroll down, know that you're there. Thank you. Some relief in sight. GEMP is helping a lot. GEMP is a new program that's actually, well, it's new to EMS. It's actually been around in the healthcare industry for, I believe, about 25 years. And it allows for us to get some compensation for Medicaid patients based on a whole bunch of math that is crazy. I won't even begin to go into it. But the long and short of it is it provides us some relief. And it provides us up to 50% of our cost of service.
What do you stand for?
Ground emergency medical transport.
Thank you. Ground emergency medical transport. Yeah. So that provides us some assistance as it relates to the actual services that we're providing that are traditional 911 type services. One of the ones that I think is in development and will assist us again in another area is the whole treat and refer idea, and that's legislation that is or has been passed here in Washington State, and that will enable us to go there, treat the patient, and refer them appropriately, and then still be able to bill them. So I mentioned that because, as I said above, we cannot bill typical non-transport services today, okay, in anything. Medicare only provides one caveat to that. So treat and refer would be huge because it will enable us to not only appropriately treat them, get compensated for that through the system, but then refer them, hopefully, some of them anyway, to a less expensive option than the emergency room, to refer them directly to their primary care provider, or refer them to an urgent care, or have them make an appointment to go see their primary provider or something like that. One of the things, and there's kind of an undertone in a lot of this, and I don't want to take up all the time here, but one of the undertones in all of this is the psyche of the EMT or the paramedic. Okay, they are all somewhere down deep. At least if they're still working, I hope they still have this in there somewhere. That they're afraid that if they don't transport the person to an ED and that person dies, okay, that they are going to be held liable. And even if they aren't held liable, you have to know what that does to each and every one of us when we learn about it later, okay? Whether we made a mistake or not, whether we should have transported them or not, okay, that does something to an EMS provider. When you know you were the last person that they called for help dialing those 3 digits, and you chose or they chose or you worked it out and you decided that that no transport was appropriate, and now they're dead. So what does that do to the psyche of the EMT or paramedic? It causes them to transport, which costs money, which can't be compensated for. So that's just kind of a nutshell view of what we face in EMS and fire. And I just wanted to make that clear. So let's talk about a solution. Let's talk about moving forward here. We'll go to the last slide there. It's also, I think it's in the PowerPoint too, either way. So this is on the back side. So if you notice there, I intentionally said funding EMS services, scratch out the EMS, funding healthcare services, because if we don't want to be an island anymore, which we don't, we want to be a part of this collective. This has to be a conversation about how do we fund healthcare in which EMS is included in the conversation. Okay, include us. And thank you again. GCACH, thank you so much for seeing early on that EMS was going to be an important part of this conversation. We very much appreciate it. So some of the things that we can do. yeah, we can continue to work at traditional funding mechanisms and improving those. GEMP is helping us do that, okay? Increasing our utility tax, yes, all those things will help. But again, at some point I say, okay, but we're still hitting our head against the brick wall. We're just continuing to do the same old thing over and over again, and we call that insanity. Thank you. Thanks, Carol. We didn't rehearse that, but thank you. All right. The other thing that we can do is have financial partnerships with our stakeholders, and that's going to help everybody. So that is business agreements, not only between hospitals and EMS organizations, but as Chief Whalen and Captain Carlisle are going to talk about here a little bit, some of the work they've been doing, being able to share information across organizations. Just earlier this week, we were at the Alliance Consistent Cares meeting, and we were talking about a patient in Richland, or was it Richland or Pasco? I can't remember which one it was. And I've seen that patient. And those are important things for us to be able to recognize so that we can collectively pull all that data together. But it's also to get these primary care physicians and clinics involved, because many of them have no idea how often we're going out to see their clients or their individuals or whatever the appropriate term is there. And if we could tie them in with the conversations. I don't know how many times in my career I made a phone call to a doctor and she's like, oh, okay, here's what needs to happen. And she knows this person very well. She knows exactly what needs to happen, and she gives us their direction, and we're able to help them. But that really needs to be formalized, and that will obviously help us all. And then the last thing, of course, is to, and that's the red down arrow, is to reduce the cost by reducing inefficiencies. How inefficient is our, and I know we all know this, so obviously maybe I'm saying something that we all know, but I ask you, everyone here, I'm not talking to that side of it, there's way too many fires in that. I'm talking to the rest of you. As you learn more about EMS, you learn more about our organization, I want you to ask yourself a question. How could working with us improve or reduce inefficiencies? How could we help you make your organization more efficient? There's obviously tons of initiatives going on out there, but I think mobile community health, call it community paramedicine, that's kind of becoming a term like seagull. You know, it's a bird in the sky. What is it? I don't know. It's white and it flies. It's a seagull. Whatever it is, whatever it ends up looking like, at every city and every organization, it's going to be different. We can and we want to be a part of that solution with you. And I think if we do that, that more than anything will reduce costs by improving efficiencies. And that is, I think, our pathway forward. Thank you. Thank you.
Our next presenter is introducing SD Cares and the Health Commons Project, Adam Davis with Puget Sound Fire. He will be presenting today by via WebEx. He's expecting him and his wife are expecting a baby any day, so we're thankful that he's still able to present with us. Adam is a doctoral prepared family and psychiatric nurse practitioner. He leads the community paramedicine program at Puget Sound Fire called the Fire Department Community Assistance Referral Education Services, which is SD Cares, and is a community health advisor for the Health Commons Project. Thank you, Eric.
Can everybody hear me okay?
Yeah. While we're waiting for him to be set up for Adam to get up, I wanted to also make sure that everybody was aware that Eric Nelson is also on our board. He's newly our board director, so thank you. Eric, where did he go? I'm like, I don't even see him anymore.
Can you hear me okay?
Adam, try it again.
Can you hear me okay?
Yes.
Yes.
Great. And are you going to be controlling the slides, or should I just say next slide?
Yeah, just say next slide, Adam, and we'll forward the slides.
All right, and interrupt me if you can't hear me. I'll speak up. Well, it's just a privilege to get to speak to this group. I'm really excited to hear kind of the quality of the conversation. I really want to amplify what Eric Nielsen just presented on, which is that community paramedicine and the community health transformation is really the ultimate team sport. And success for us is really about breaking down silos and building partnerships and networks. We can't succeed at taking care of these people with complex needs in our community by ourselves. It really takes integrated teams across the health and social service spectrum to move the needle on this population. What I'm going to share today is really about how we're transforming care in South King County through two related innovations. One is a community paramedicine program that we call FD Cares. And then the second piece is a quick intro on the Health Commons Project, which is a nonprofit organization that helps communities set up, deliver, and sustain whole person care services. And I'll talk about how these innovations are related and how they work together. Next slide. So there are really a lot of different types of community paramedicine programs at the regional, national, and international level. This is really a new service, similar to the transformation that went on 40 plus years ago in the fire service, where they moved from fire to EMS. This is kind of that next innovation cycle. Fire departments recognize that there's this new need in the community, and so we're trying to figure out how to meet that need. So FD Cares is really just one flavor of community paramedicine. We don't pretend to have all the answers, but we're in the field working on how to meet this community need. Very simply, FD Cares is a core service of the fire department, just like hazmat, swift water rescue, fire prevention. FD Cares is just another core service, and we're specifically designed to connect community members to whole person care. And we do this by operating mobile care teams that both respond to 911 callers with low acuity needs and connect them to the right acute care services, primary care, urgent care, behavioral health care, shelter, durable medical equipment, prescription medications. And then when our teams are not responding, they're working to proactively identify, outreach, and engage people with complex needs. Get into the home or to the community setting, make a whole person assessment, and try and connect them to whole person care services in the community. Maybe our best analogy or explanation of what we do, it's really a fire department adaptation of the Camden Coalition's hotspotting program out of New Jersey. And I'll give you a quick example of a success story to try and bring this work to life. So we recently had a client by the name of Betsy Jones. She called 911 for a non-injury lift assist. And after lifting her from the floor, our mobile care team conducted a holistic 360-degree assessment to learn that she had frequent 911 calls and emergency department visits. It was clear to us that she was unable to care for herself at home alone. She had no social or family support, and we learned that she is diagnosed with end-stage cancer and wasn't connected to any kind of care in the community. So over the next 2 months, during repeated 911 calls that came into the CARES unit and proactive outreach visits, our team worked with Betsy to transition her into an adult family home. We scheduled visits between her and a primary care provider, which we attended, and we enrolled her in a palliative and hospice care program with the help of her primary care provider. So as a result of connecting her to the right care in the community, she was able to experience a death with dignity in the adult family home 3 months after our first contact with her. Next slide. So we all know that our current response systems aren't well designed to take care of the Betsy Joneses of the world. And what we really believe is that community paramedicine is a key service that can help connect and coordinate care for these people with complex needs. And there's a couple different reasons that I want to lay out. One is that as a fire department, our funding source really is tied to the community. We are directly and almost exclusively accountable to the community for delivering high-value services and high-value care. We don't operate in the fee-for-service system, and so we have the time and the space to really do some of the whole person assessment work to understand the root causes of what's going on with people with complex needs. And the third point is we're mobile. We operate in the community. We're in the homes of individuals, and so we really get we have a different lens than folks who operate in the kind of the clinic setting. So we can be the eyes and ears for a lot of our community providers. So we've talked a little bit already, Eric did, about this kind of growing problem. You know, we have this growing percentage of low acuity calls, and the 5% of population that account for 50% of healthcare services. And the Center for Complex Needs has really helped us get a framework for how to understand these populations a little bit better, as breaking them down into categories of people with medical needs, behavioral needs, and social needs. And I won't go through these population segments, but these are really the different groups that we interact with who are calling 911 for low acuity calls, or who are our kind of high risk repeat users. And so we, kind of recognize this through the growth of our program. And so we partnered up with the Institute for the Health Improvement and the National Center for Complex Health and Social Needs to really design our approach to deliver complex care. And over our 8-year journey, we really have some unique elements of the FD Cares approach. One is that we've designed FD Cares as a core service of the fire department so that our community paramedicine program can be sustained within the fire service. We've also designed it to scale. So we wanted to put something together that could be a shared service or shared resource that could be adopted by other fire departments in our region. So we just launched this year a partnership with Renton Fire, and we now have 2 cross-jurisdictional units that serve Renton Regional Fire Authority and Puget Sound Regional Fire Authority. Next slide. So let me get into the details of how FD Cares works. So our first care model is really about right response, right care. And this image comes out of CMS's recent ET3 innovation, which is ET3 stands for Emergency Triage, Transport, and Treatment. And so this workflow is really, what they believe is the North Star vision for how 911 medical services should be organized in the community, and it's fairly similar to what we're building. So how it works for us, we have our primary mobile response teams. We call them Care 7-1 and Care 7-2. Care 7-1 is a 24-hour unit. Care 7-2 is a 12-hour unit. Both are staffed with a firefighter, EMT, and a registered nurse, and they operate a truck, a Chevy Silverado, rather than an aid car or a ladder. These units respond directly to low acuity 911 calls through a criteria-based dispatch system, and then they can be deployed by other response teams through a downgrade protocol. So when our care units gets dispatched, what they do is they conduct a reverse telephone triage to the 911 caller to confirm that low acuity disposition and that the client is comfortable waiting an extended response time. And then we proceed without lights and sirens with up to 20-minute response times. When we arrive on scene, the firefighter EMT does an initial assessment to determine sick, not sick. And once we confirm the client has a low acuity need, we do kind of a more holistic assessment to try and connect the individual to the right services. When our Care 7.1 and Care 7.2 are not responding to low acuity needs, then they're working to identify, outreach, and engage these people with complex needs. Next slide. So our secondary care team is a group of social workers, and they're really our Care 7.1 and Care 7.2 team are really more transactionally based. We want to have them in service so that they can respond to these low acuity calls, and then they will hand off care often to our social work teams, which can do this more intensive whole person assessment and kind of getting to root causes with some of these more complex individuals. So, and we employ one social worker on our team, and then we've partnered with an organization called REACH, which, so we subcontract to have 2 other social workers that work with our team. And REACH is really focused on serving individuals who are homeless or unstably housed. They recently helped our highest utilizer in Puget Sound Fire get transitioned into supportive housing. This was an individual who had over 100 911 calls related to missed dialysis appointments. And so we now have her in supportive housing and haven't had any calls for the last 4 months. So that's been a great partnership. So this is kind of the end of the FD Cares part of the presentation. And let me just say that our North Star is still probably, step 30, and we're on step, 5 or 6. What we've learned over the course of this journey is that we're really asking our care team right now to be provider heroes because of the amount of care coordination work that they have to do to be successful with the clients that they're taking care of. And so that really, that need to simplify the work for our care teams really helped launch this next partnership with the Health Commons project that I'll touch on briefly. Next slide. So the Health Commons project is a collaboration between communities, health and social service organizations, and technologists from across the state of Washington, including Greater Columbia, and especially Greater Columbia Accountable Community of Health, folks at the Kittitas County Health Network. Dr. Martin is one of the lead physicians that's been helping to get this initiative going, and then individuals over in Olympic Community of Health and providers in South King County. And the Health Commons project is really about helping local communities set up, deliver, and sustain these personalized whole person care services. The project partners with communities to help align the people, process, and incentives so that we can deliver, create a kind of community health system that can have the right digital tools and the right processes to work together as an integrated team to take care of these complex patients. Next slide. And the need for the Health Commons project really came out of the need to serve these three primary groups: people with complex needs, which we've talked about at length, these caregiver and provider heroes that need better systems and tools to coordinate and deliver whole person care, and then community leaders who really want to see this more connected health system, but need help with the organization of services and finding the right tools, IT networks and systems to make the information flow between providers. Next slide. So how does the Health Commons project work? About 80% of the work is really focused on helping communities align people, process, and incentives to solve these very complex service integration workflows, IT, and payment issues. For example, how would you integrate community paramedicine into primary care or into an emergency department workflow? And how do you get paid for those services? And what digital tools do you need to be able to make the information flow between providers? The second part of the work is really about identifying, installing, and managing those IT tools and networks. And the way that this is being done is not creating new digital tools, but actually identifying the need and then shopping for best-in-class tools that are already on the marketplace, and basically connecting those tools, doing group technology purchasing to connect those tools into the community. Next slide. So what's our goal? Well, Health Commons project goals are very much aligned to what we're trying to accomplish with our community paramedicine program, which is to identify these individuals who are using the most expensive services in the community and see if we can get them engaged in community-based services that are ultimately going to better serve their needs. The fact that 3 days in the hospital equals 3 months in the county jail equals 1 year of affordable housing, it's obvious that we all want to see us, investing more of our resources in those tier 1 services. Next slide. And one of the benefits of this partnership with the Health Commons project has been the shared learning and shared IT costs that we can access by working together with partners across Olympic Community of Health, across Greater Columbia Community of Health, and South King County. There's a lot to be learned, so we don't have to reinvent the wheel, and then we can also share the costs of some of these more expensive, best-in-class digital tools. Next slide. So lastly, both our effort in community paramedicine and this effort with the Health Commons project to deliver whole person care services, we think are really well aligned to what's going on at the national level, at the national conversation. The ET3 grant is really trying to incentivize communities to adopt this community paramedicine service, and CMS recently awarded a grant for North Carolina to pilot test this kind of whole person or enhanced case management service, where they're actually paying for things like excavating a home of mold for a moldy home for a patient with asthma or COPD, starting to put these health and social service payments together. So that's definitely the direction that we want to head as a community paramedicine program, and that our community wants to head. Next slide. All right, and I'll finish there.
Adam, thank you very much. Very informative. Does anybody have questions for Adam? Actually, Adam, I have a question for you. In your in-home whole person assessment, do you think that sort of an assessment in that setting provides an advantage versus an assessment that might happen within primary care or behavioral health agency? Is there some added benefit by being in the home when you're doing that assessment?
I certainly think so. You know, similar to kind of how, well, let me just say I've worked on both sides of both sides of the coin. I've worked in the clinic setting, and I've done in-home care both through this program and through a home-based primary care and urgent care program. And there are a lot of insights to be gained, not only from, you know, the home environment and seeing how the individual kind of lives their daily life, but also to connect with family who might be there, or to get a sense of what level of social support this individual has, and have the time to see, to do like a brown bag session, you know, that you might normally do in the clinic setting, but really to see, you know, what's going on with how they take their medications. Is there food in their pantry? You know, are there kind of unkept conditions? There's a layer of insights that come off of that home care assessment, especially when you get into social determinants and behavioral health.
Thank you. And by the way, Adam talked about the health commons in Kittitas County, which has now gone into production. We're really excited about the work that they're doing there. Also, the apparent winner of the Opioid Resource Network here in Benton, Franklin, and Walla Walla, which is a collaboration between Consistent Care and Blue Mountain Heart to Heart. We also hope to have a health commons network aligned with the implementation of that project as well. And there may be further health commons coming on later on. Dr. Taylor, you had a question?
Yeah, even if we show can prove this is highly effective for keeping people at ER and so on, are there any comments about financial sustainability of this long term?
So, Adam, the question was, are there aspects around financial sustainability of this work going long term?
And is that about the community paramedicine aspect or the Health Commons project?
I think it was focused on community paramedicine.
Yeah, so I mean, the way that we've you know, set this up for sustainability in our organization is really that the fire service believes that this is, you know, the next core service that they want to deliver to their community members. And you know, there's kind of two ways that we're delivering value to the fire service and to the community. One is we're you know, providing this better quality service to high needs people that would ultimately be you know, using more expensive care resources, and using, you know, 911, the 911 system, taking our rigs out of service and leading to, you know, increased 911 call volumes, which means you have to buy more fire stations and more fire departments. So we're kind of bending that curve. We actually have anecdotal data showing that for the first time in 30 years, our call volume, 911 call volume, did not increase for the last 18 months. Typically, it increases every year about 6 to 8%. We can't confirm with 100% certainty that's because of the CARES program, but we're highly, we believe that we're having a pretty big impact. So that's the number one way that we're helping sustain the service. The second way is by looking for sustainable revenues outside of the fire service. You know, we talked a little bit about the ET3 innovation that could provide a funding resource, and then there's also the treat and refer, treat and release payment.
Thank you. Sam is looking at me behind me. We'll take one more question. Barbara, did you have your hand up? Okay, thank you.
Our next presentation is Fire Department Community Assistant Referral and Education Services, FD CARES. Presenting today is Bill Whalen and Paul Carlisle from Dayton County Fire District. Chief Whalen was born and raised in Las Vegas, Nevada. He joined Las Vegas Fire and Rescue in 1982 as a young 20-year-old firefighter and proudly promoted his way to the ranks to the paramedic, engineer, captain, and battalion chief. He retired from Las Vegas Fire Department in 2010 to accept the position of deputy fire chief in Hemet, California. While in Hemet, he also filled the position of interim fire chief. Bill and his family relocated to West Richland in 2011 to accept the position of fire chief for Benton County Fire Protection District. Number 4, Chief Whalen is enjoying his 7+ years in the Tri-Cities area of Washington State. He is committed to serving the residents and visitors of the community and is passionate about being the fire chief and the challenges that the position brings. He appreciates the support of his commissioners and residents and is excited about the potential growth and development of the fire district and community. Chief Whalen is honored to have his dedicated 37 years thus far to the fire service field and is enthusiastically embracing the ever-changing needs of his chosen career path, the fire department. Captain Carlisle was born in Tacoma and moved to the Tri-Cities as a child. Captain Carlisle started as a volunteer fire department, progressively moved up to become a volunteer lieutenant. In 2006, Captain Carlisle was offered a full-time career position with Benton County Fire Department number 4. In 2007, Captain Carlisle became a lieutenant with the department. In 2013, Captain Carlisle was promoted to a captain. He is also the Benton County Fire Department number 4 EMS officer. His passion for emergency services has brought tremendous knowledge. In his time off, he enjoys boating, motorcycling, and spending time with his family and friends. Welcome.
Hello, GCACH members and all the audience members that aren't part of it. But I appreciate you allowing us to come and talk about our program here, which is we're really riding the coattails of Adam Davis and Puget Sound. I want to thank them and really identify with them because they're the ones that gave us the idea to implement this here in Benton County Fire District 4. I'm going to give you a little bit of a short story. You guys heard where I came from 37 years ago. During my first year, I remember one patient. This was 37 years ago. Responded to him 4 times in one day. This was 37 years ago. The person had a lot of health problems, a lot of mental health problems, and we kept doing what we've always done in the fire services. You call, we haul, that's all. So we dump them off in an ER with all you nurses. You're mad at us. Why are you bringing them here? Then we finally said, okay, we're going to do something a little different. Now we're going to take them to, an alcohol rehabilitation center. Oh, we send them to them. They turf them. We see them 4 times in one day. This was just one day that I got my introduction to this man. It was amazing for me to think, man, this just doesn't feel right. We've got to do something different, something better. We're not getting this person to the right place. And thanks to all of you and the mindset that we have here, the fire service has the opportunity now to do something different. We have an old saying in the fire service, 200 years of tradition unimpeded by change. I'm telling you, that is a true statement for the fire service. We all work in our silos, we all do our own things, we all do things differently, but we're doing it for the same cause. We really, really are. And meeting up with Adam Davis and Puget Sound Regional Fire Authority, Mitch Snyder, who is now Gresham Fire Chief, Gresham Morgan's Fire Chief, he was the one that I got to meet with. When I got here in 2011, Captain Carlisle and I looked at, hey, what are we doing? We need to do something different because of what I saw 37 years ago as a young firefighter. I knew we had to do something different. I didn't have the ability to make those changes. I asked him what he thought. He said, most definitely, that's what we need to do. So we started researching different community paramedicine models, mobile integrated health, all these different things. So we landed on FD Cares, and we know it's a mouthful, Fire Department Community Assistance Referral and Education Services. But we felt that it had the best opportunity for success in our community. So it's helped us to identify a lot of things we didn't know, and Adam and his team has helped us kind of carry through with a lot of different things. And so we're really proud to be part of this. We just learned about the Health Commons Project, which is, I believe, the next evolution of where we're going, and I think it's going to be part of all of this in this room. We're all going to be a part of this because we're going to be able to talk to each other one day and find out who these patients are that we're seeing. Maybe we see them first, maybe you see them first, but we can make a difference. And fortunately for our organization, we are in a combination department. We have volunteers. We have volunteers that full-time job, full-time family, and they volunteer as well. And so we're just so grateful to be able to have that. and we can help reduce the cost for our organization. That's why being as small as we are, we can do a lot in this small agency. And I do have to kind of reach out to Captain Nielsen because he's back there. I never did tell him to shut up. I promise you I didn't do that. Because I respect the man too highly and what he's doing and everything he's done for this area prior to my arrival. He's a very, very knowledgeable guy, and I appreciate him. I didn't tell him to shut up. What I did tell him was when he said, well, you know, we don't have enough resources. I'm like, really? You have almost 100 members. I have 14 career members. I think it's just a little overshadowed. Really? That's what I said. But the person that really makes the magic happen is Captain Carlisle, and he'll get to a piece of this and explain what he's doing. And there are some things here that this solution works for us. Hopefully, you know, we can make this thing bigger and better with all of us. So what we wanted to do is define the problems. As you well know, every sector of the healthcare, all of you, you know, are remaking itself in response to healthcare reform and economic market forces that are demanding better value. Juan Lopez is the one this was quoted from. You guys are all having to do things differently. We are too. 200 years of tradition, unimpeded by change, that's not how it works. And this is a prime example from General Eric Shinsky. If you don't like change, you're going to like irrelevance even less. Look what happened to Blockbuster. Back in 2004, $6 billion. 6 years later, in 2010, they were bankrupt. But if you take a look at Netflix started off really small, and they kept growing with new ideas, new innovation, new changes. They stayed in the market. They're still here today. That's what we have to do as a fire service. There'll always be fires. There'll always be medical calls, because what I tell everybody is when you don't know who to call, who are you going to call? It isn't Ghostbusters. It's going to be us. You're going to call us. You really, really will. And we're not really well equipped to deal with all this. All of you guys are. But if we can get these people that are calling us the help that's needed to engage with the right folks, aren't we doing better for our communities overall? Truly? I think we are. That's why I said when I got here, I want to do something different. Coming from Vegas, like I said, we talk about our call volumes. When I left Las Vegas in 2010, 96% of all the calls we went to were EMS. 2 doctors on staff, 4 nurses. We didn't even do community paramedicine. I kept preaching it. Kept trying to get some attention. Nothing. Since I've left, they've done a lot of things. Trust me, they've done a lot of things because they've identified when we were running 100,000 calls a year, now they're at 130,000. They had to do something different. Same thing we are. Adam talked about the increase in call volumes. We just saw a 17% increase in call volume in just our little community. Now there's some growth issues that come along with that, 17%. What we're hoping to do is offset that just a little bit with not having the emergency calls. Captain Carlisle, like I said, he does the magic. He gets out there, he talks to the public, he makes things change for our organization, which is still capping that call volume somewhat. How do you manage, how do you get a hold of that and track all that? Well, that's what we're all here to do, hopefully do that. So the need for transformation. You know, our current response system is not a sustainable path. Responding with large apparatus and non-emergency medical services, or NEMS. That's what we do. Typically, we will do that. We will still do that if the 911 call comes in, because Eric brought it up. We have to. We have an obligation to respond. We will come to those calls if it's through 911. But if we can give them another access point to call us, that we don't have to send these big rigs, that would be great. Do we have to respond with a paramedic to all NEMS calls? No, is the answer. We don't have to do that. We can go into these homes. We can look at these people. We can do what I call the detective work and see what they really, really need. And then we can tailor something by reaching out to you guys, because now I have contact with you. When I was in Vegas, I had a lot of contacts. I'm still trying to build all my contacts here. The other thing is we respond with 3 or more firefighters. Do we always have to do that? Captain Carlo is going to tell you he responds by himself to the ones that he feels comfortable with. And when I'm available, I'll go with it, because that's how small we are. We have to have the fire chief going out to these calls and helping out too, because we still have a 17% increase in call volume for other calls. Transporting all or most patients to the emergency department. We need to stop. You call, we haul, that's all. We have to. We have to stop that. I remember nurse after nurse after nurse coming to the ER and saying, why are you bringing these people to us? They don't need to be here. We don't have any other options. That was the answer. That was our job. Our current response systems are not well designed to address the 911 callers with low acuity complex needs. Just like Adam said, growing percentage of EMS calls are low acuity. 5% of community members eat up 50% of all of our healthcare resources. For us, that's even harder because we are so small. And I think Adam's already covered this, so I don't want to go through this slide again because we are partners with them. That's why you're seeing double slides. So the other thing that we found that was important to me, because I'm the fire chief and I asked them to keep me out of jail. That's all I'm asking them to do. So the other thing that they did back in May 15, 2013, they had FD CARES legislation passed. It says we can do this now. This is the RCW 3521-930. Don't take my word for it. Please look it up. This gives us the ability to partner with you guys. They actually went out and did the legislative piece so that we can do this. So that no one can say, you can't do that. You're just the fire department. Yeah, we're just the fire department. Who else you going to call? You know who it isn't. So how did we get started? You know, we started the program. We found this FD CARES project was way better than what we could have ever hoped for. We're riding the coattails of a larger agency that has the resources to develop something even bigger. But we want to do that here in a smaller perspective with all of you. That's what we want to do. Fund the program. That's a tough one. We're doing this through our own budget right now. We're grateful to see that there are some federal assets that are being changed to say, hey, look, we identify what you guys are doing. Could save money for all of us. The hospital. The data piece, Captain Carlisle is going to talk about that. We actually have a database that was the CARES program, which really helped us identify even more. Actually, Captain Dunbar, who's now with Pasco Fire Department, we all sat and talked. We thought we had just a few, maybe 6. What we thought, because we see these repeat calls, we thought, we got about 6. Now, Captain Carlisle is going to tell you how many we found by using just the database to figure out what we were missing, if there was something we were missing. And then, you know, hopefully it'll just keep cycling and we can keep getting better and bigger at this. Community paramedicine setup, assess the scope of the problem in your fire department community. The thing is, this is everywhere. You know, we all have something a little different than the other community members here. Pasco has their, you know, higher levels of certain types of patients. We have ours as well. So you got to look at it, and then we got to go out and figure out how are we going to get them to quit calling 911, call us. We'll come to you. You just got to call us. We'll provide a service to you. We promise you we will. Whether it's through 911, which we all respond, licensed siren, that's the most dangerous times for any fire department. Unfortunately, where I came from, we had a couple of accidents. One of them resulted in one of our members being a quadriplegic. And it was on a 911 call, so he false alarm. Quadriplegic. And then we had 2 other members. One was cut up really bad. 2 others wanted with back injuries for the rest of their career because we rolled an engine. We don't want to respond to 911 calls to these low acuity calls. What we want to do is respond to non-licensed sirens. A very important element for all of us to see and try and figure out how to do that. We need to co-design the service model with partners, all of you. Every single one of you has a piece of what we do. We see all of your patients on a smaller scale than you do, but if we get them to you, you guys can take care of them better than we can ever dream of. So we've actually launched a community paramedicine service. We installed IT tools, you know, reporting metrics, things like that, from FD CARES. That's what this was. We knew we needed something to come out and show you what we can do and what we're trying to do. The Health Commons Project, I believe, is going to take it to that next level, where we won't have 5 or 6 databases to look at, see who these patients are, and where do we need to take them, what do we need to do with them. Well, with that, I'm going to introduce Captain Carlisle to you guys, and I thank you again for at least letting me try to talk. I know I talked too much.
Good morning. Thanks for having me. I'm going to go over the FD CARES database. It's going to be a really short presentation. We have another PowerPoint. It's going to be way longer than we have time for today. One of the things that the fire service is really good at, we're really good about collecting information and data. We weren't the best about how do we aggregate this and what does it mean on the backside. So,
quick question.
Sure.
Is PowerPoint going to be online? That's right.
Yeah.
This PowerPoint?
Yeah.
Yeah, and if maybe we can give the other PowerPoint to show it.
I mean, just so we don't have to take notes.
Oh, sure. Yeah.
Anything we've covered will be on.
So, John, the recording itself, I'm speaking here in the back of the room. The recording itself that Lauren's recording off of GoToMeeting with sound will be posted on our website and also another website that we're working on. So anybody who wants to go back and listen to the recording, see the slide deck, they'll be able to do that.
So one of the things that we identified is what do we do with all this information that we have? We had a two-part problem here regionally. We just relaunched our records management system. All the key players here have done that, but this is also another database that augments that. So this was a database that came out of FT Cares. Like I said, we signed up with them, and what it's going to do for us. So the first thing it does is it takes this data and allows us to clean it. As we all know, sometimes we can misspell names, date of births are entered wrong, addresses are wrong, but how do you identify that? So this database allows us to take all of our records management system, dump it into one place, clean the data, look at it, and then it does some other things here. So this is an example. This isn't our live database. On here you can see system statuses, how many patients, incidents you're responding to, activity, things like that. On the right-hand side, though, what it does, it allows you to start tiering your patients out. And you can see the categories that it falls in. And it basically goes from your low-hanging fruit, people you can make a quick impact with. Maybe they're the patients that you see that are fall patients in the home, but it's because they don't have a grab bar or wheelchair ramp, something like that, all the way to category 9, which is a mental illness or a really high needs patient that you know is going to be your long-term patient that you can't make that quick impact with. So it tiers them out for you and allows you to just kind of start categorizing your patients. One of the things that we realized when we did this, before we went and did this, we sat down as a group at our agency and said, well, how many repeat patients do we think we have? And part of the problem with the fire service is you always have changing shifts. And one shift may respond to a patient, but the other shift's never seen them. So we, in our wisdom, said, well, we have about 6 in our area. When we did this the first time, we quickly identified that we had 25 of the category 2 patients. So it was this huge spike in numbers. We're like, this data's got to be wrong. This is not correct. When we went back and looked at it and made sure the data was clean, it was absolutely correct. And then the other categories really popped up too. So we quickly realized we had a bigger issue than what we thought we had originally. So by dumping our data into this, it was like, wow, we can now take a bigger look at our area and see what we're doing. West Richland, or Fishing County Fire Number 4, services the city of West Richland plus the surrounding county areas. So we're one of the smaller agencies in regards to population. We didn't think we were going to see the numbers that we saw. So when you extrapolate this out to another agency that's running a lot more calls, higher population, it's probably the kind of the same thing that you go, wow, we didn't realize what we didn't know at the time.
So Paul, what's the difference between that right-hand table and it has tier 1, 0, 13, 13, and then on the right-hand side, patient category status with 72 United States, or here's the difference?
So in each tier, under the categories and tiers, you have subcategories or sub-tiers, so it's just a different way of breaking it out for you. I removed a slide just in the interest of time today that I originally had in here that broke this out, but we can get that data for you if you guys would like. With this database, at the very top, you can see across the board here, there's a lot of drop-down menus and things in here. So there's a lot that you can do with this database, all the way from patient intake, tracking your FT Cares patients or community paramedicine patients, and then also doing your chart notes in there. And so this is where you can hold all of your community paramedicine chart notes. This is just another quick glance. It kind of tiers your patients out. Again, this is the tier 2, your lower acuity quick patients you can make a definitive impact, and then shows you, for example, how many incidents, transports within the last 30 days. So it's a quick dashboard to look at everything and see where you're going with it. One of the things, and I can take the slides out just in the interest of time, we've had some really big successes with this after we identified our patients and their needs. We do have a patient in our area that was on track to be activate the 911 system for almost 100 calls that year for one patient. They fell on this tier 2. She's a success patient, but we've also had some struggles with her. We have lowered that down to about 75 911 activations, but we haven't completely gotten her out of the system. But we have had other patients where they popped up on our radar, and all of a sudden we have 5 911 dispatches within the course of a week, and we can go out and we can do that at-home visit, take a holistic approach, and go, what is the root cause of the 911 activation? We found that 911 activation was the need of a wheelchair ramp. And when we tied into the community and said, okay, who's our community partner that can build this wheelchair ramp, that person has completely disappeared from our radar and has no longer activated the 911 system. We had the same thing. We had another one where they were activating 911. They also had 13 ED admissions or ED transports. What we didn't realize is that was a med issue. And so when we went out to the house, did a holistic approach to it, we realized we had a med conflict from 2 doctors prescribing medications that were causing issues. So with Benton 4, we actually have volunteer nurses. We also have a PA. So it was a great resource for us. So I just called up and I said, I think I have a med issue here going on. Can you review this case for me? They reviewed the case. They actually went out and tied in with the patient's 2 doctors who have been doing the conflicting medications, and that person's completely dropped off our radar now. And it was just the case that both doctors didn't know what was going on. But by being able to go out in the house, identify the patient, and see what their needs were, we were able to completely stop 911 activations and ED admits. So those are a couple of success stories. We have more, but we're some time here.
I have a quick question.
Sure.
So what does it look like? Like, say you get a call from 911. Are you able to look at that person and say, oh, that's a little cutie, we need to get that staff out? I mean, how does that work?
So right now, we are not as far as like Adam Davis spoke at. We are more retroactive. So how we're getting Benton 4 right now is normally it's going to take a 911 activation. The crews respond. They'll either refer the patient to me. If they go, hey, this is an SD CARES patient, we really need to address it that way. Or after so many activations, they'll pop up on our radar here, and then we can see it. Again, sometimes, like I said, because we have 3 different shifts, and you never know where those crews are, it may be one station responding today, another station responding tomorrow, a whole different crew set, so they're not globally putting all the pieces together from this. So sometimes we don't identify them until after we've had so many 911 activations, and we go, okay, why do we have 4 activations in the last 30 days? What's going on here? And let's go look at this. And that's where I'll step in, start going through all the charts, reading it, see if I can make a correlation. I'll call the patient, I'll go do home visits, things like that to get out there and figure out what's going on. So we're not as far advanced as Future Regional, or I can always have the name of Regional Fire. Yeah, there you go. So right now we're more retroactive, but the crews are doing a great job. That has been a struggle too. It's like, hey, refer people to me. Let me know what's going on. They've gotten really good about it here in the last year, just identifying these patients really quick and then just right on to it right away.
One of the things to take just a snapshot picture of, Puget Sound Regional Fire is much like this entire region, the same size from a population and response category. They really are. And so all of us together, we have to work together to be able to have those same kind of numbers and the same success ratios that they do to really see the impacts for all of you. So the one thing I do want to comment about the one person that we reduced from 100 calls to 75 calls, there is one other small reason that she continues to call. These guys are so nice, and a lot of these firefighters are looking and young. She wants to visit. So it's really, and they're so nice. She wants to call. She wants to call and say, so what can we do about that? Nah, I don't know what we can do about that other than go visit with them because they really are nice. We need to transform the way we're delivering care to our community members, and I'm really happy that you guys showed up. And, you know, the GCACH is what this, I think, is going to bring us all together and put us all in that hub together and the Health Commons Project that will really do that even bigger. We got to stop working in our silos, all of us. I mean, all of us do that too. We all have, this is important to us today. Reinventing the wheel is not working. Why would we want to? That's why when I identified this program, after all the ones I've reviewed, I went go down to Anaheim and rode along with them to see what they had to offer. This was the one that I said, this is working. You know, Captain Carlisle went with me. We've actually taken our PA. I took the PA with me down to Anaheim, looked at their program. He looked at this and he goes, this is way more robust, and this is something we think we can implement here. We've done it. But we need partnerships and networks to transform our services. Like I said, if you want to talk with any of us, the one thing that I can tell you from our kind of a grassroots approach, you talked about funding. We don't have that funding. But partnering with you, we can. You know, what better organization to partner with that has facilities in those areas that you need to be in? We're within a 6-minute response time of the majority of everybody we're talking about. We are the person that you want to partner with. You send some of your folks with us, we'll take you out. We'll go with you to the calls. So we can do those kind of partnerships to make this work even better. I really believe that. And so I appreciate your time. I don't know if you've got anything else to say. With any more questions, we'll gladly entertain some questions if you guys have any.
I have a 6 for you. that gal, you could just send out a female.
We do that too, just like her. Well, we like her too. We have to get on her too, and we can't join them all because they're all, and that's a testimony to the staff that we have here. They're all very nice. They understand what we need to do with our patient, but she does. She calls her too.
So when you're working with the public, like, the work. So what question is also mental health. Would that be?
Without a doubt. You're 100% right on. But you can ask Eric. I don't do anything. The fire chief, all I do is point and drag. I don't do anything.
Okay,
So, but I'm one of those ones that go out, like you're saying, and it does eat up a lot of my time. I have other things. Captain Carlos, the EMS officer, he had a ton of stuff to do, just like these other EMS officers over there. With partnerships with those particular groups, without a doubt.
All right, so I was just thinking about community health workers, peer conflict teams, where, I mean, you guys are looking for solutions.
Correct. We are, always.
I'm just thinking that teams work together, they get a lot of things accomplished. And with the diversity and diverse knowledge that each comes with, we would have access to the knowledge about mental health, know about mental health disorders. You follow these people into it, people interested that they're doing outside of what
That is exactly what we're trying to do. We want to get to the CARES unit level. We just haven't made it there because of our limited funding and resource ability. So we really want to get to that. And any partnerships here would be greatly appreciated. We'll talk offline with anybody. We partnered with the chaplaincy here. They've been really good with us. We identified some things that we didn't even know were occurring. They had people that were palliative care members. We didn't know that they were in our community. We had hospice members that we were responding to and transporting. They didn't want to be transported. They didn't have the right paperwork. We've partnered with them and we've identified just in our little area, hey, we're not going to do that unless you really want us to transport those people. These are the things that we're doing, just what you're saying. That's a small level. That's why this is so important. I can't say enough about what this group is doing. You guys are way smarter than me. I'm just a fire chief and all I do is point and try and make things happen. So, but that's a great comment, it really is. So we're all ears. If you guys want us to come, we'll come there and talk to you and see what we can put something together and work through this.
Yeah, and I think to reiterate that, most of these home visits that we do, my next step is to refer them out to the community organization, whether it's Catholic Healthcare, Catholic County Services, aging long-term care. So we've been working with all these other entities to try and identify the correct need. We don't do wheelchair ramps and like that. So as soon as I identify the need, it's like, let's get them out there to whoever it needs and stuff like that. So realistically, a lot of times we're a huge referral source, and because the individual doesn't know what's out in the community or how to get the care or the help they need. So that's what we do. A lot of time is a site visit, and then the other part is trying to find the right organization for the time to do.
What about community programs and partnerships? Networking with those partnerships, be able to create an idea around that community program that would bring that.
And that is a possibility.
Can you reiterate? Yes.
I'm sorry.
For the people on the phone, can you repeat what she just said?
The question was, are there community block grants available? There's a lot of grant opportunities available out there, some of which we're not able to do because we are a fire district. We're not a city entity. A lot of cities can do the community block grants and do things like this. We're a standalone entity. We're the fire service. We don't, that's why when Eric talks, I kind of laugh because he has, a city entity, has city shops, city attorneys, all the other things the city has. That's us. This is the only two administrative people other than one other person that isn't here today. We're not eligible.
But in partnership with those
Yes. Yes.
that could be a realistic goal, right?
That is correct. And we can all do this if we're all working together as a united front. That is correct.
You're from District 4. Are there other districts in Benton County that have
There's 6 other fire districts. There is a hospital district that you're going to hear from that's done some amazing work. They're, you know, part of the Foster Hospital, so they can do things differently than we can. And so, yes, there are some that are out there. Every one of these gentlemen over here that you see are doing something. They're just doing it the way they need to do it because their communities are different. But yes, everybody's doing something. A lot of the districts that we have are very small. They even have fewer resources than I do. And so it's really, really tough to make a difference. So yes and no is the answer. Thank you, guys.
2 more presentations, and we'll have a panel discussion. So we'll have ample opportunity for additional questions. The next presenter is, the title is Foster Community Paramedicine Program. We have Carla Green and Tyler Platt. Carla Green's nursing career spans over 20 years since graduating from Washington State University. Carla has spent the majority of her career in the emergency department, where she is a double board certified in emergency nursing and pediatric emergency nursing. Her current role at Crossing Memorial Health, PMH, is diverse, and for the last 5 years have included bedside nursing, as well as the opportunity to work as their community paramedic program coordinator. During her time at PMH, Carla has enjoyed watching her paramedics grow into their roles and take ownership of the program. She also enjoys watching community paramedicine take hold in healthcare and benefits of these programs being recognized. Throughout Carla's career, she has also had the pleasure of teaching first-year nursing students at Heritage University. Tyler Platt has been working in the fire and EMS industry for 11 years. Currently, Tyler is the Director of EMS for Crossing Memorial Health, CMH, which provides 911 response to community paramedicine to Western Benton County and parts of the Lower Yakima Valley. Tyler is a paramedic by trade, although he also volunteers as a firefighter at Benton County Fire Protection District 2. Tyler attributes his fascination of medicine to his continuous drive in the industry and is eager to continue working towards his master's degree as a physician assistant. Tyler gathers the majority of his experience from various fire departments in Western Washington. Tyler moved to Benton City 4 years ago. Although he feels as if he's at home, he enjoys meeting new people and treating patients. Welcome then.
Good morning, and thanks, Sam. As you said, I'm Tyler Platt. I am the director of the EMS program out of Foster Memorial Health. I am fairly new out there to that position, but I've been out of Foster for the last 3.5 years, working as a paramedic there. I've seen intimately how well our community paramedic program works firsthand, as I've been part of one of those paramedics. As the director, I operate an ambulance service where we have 2 full-time ambulances staffed with a paramedic and an EMT or an advanced EMT. We provide 911 services. We also do interfacility transfers, and we have a pretty huge area that we cover. We cover the Western Benton County, if you're not familiar with where Prosser is, it borders Yakima County, excuse me, and we also cover parts of the lower valley of Yakima as well. So what I'm going to do is introduce you to Carla Green, as you got some of her information. She is the expert in our community paramedic program, and she's going to have a lot of answers for you. As far as how the program works, we heard a lot about the FD cares and the 911 calls. We will address some of that, but we have actually a unique perspective on how a community paramedicine can work from an ambulance and hospital-based perspective. So here's Carla for you.
Thank you. You guys already heard lots of stories today, so I'm going to flip through a little more quickly because I think you have a good grasp of what community paramedicine and FD cares programs do. We are the weird one here because we are not a fire department. We are hospital-based. We are part of a public hospital district, so we are a tax-based entity. We actually started this program in 2012 with a CMS grant that we were awarded. So we are little. We are last access hospital. Our area that we serve goes all the way from Sunnyside with our community paramedic program. We go Sunnyside all the way to Benton City, all the way to Patterson. So we actually cover. I asked him, well, how many fire districts do we cover? He said 3. I don't know. Whatever he says. We also have a lot of clinics, and obviously we have the hospital. One of the things through the years I've had the opportunity to speak about paramedics, even though I'm not one. I'm an ER nurse, but I love my paramedics. but they don't come up here and talk as often. I don't know how y'all got them to do it. It's wonderful. So, through the years, what I've seen working with this program is that paramedics are very uniquely qualified. And I think this question a lot. Why do you send paramedics and not nurses? Well, first of all, nurses are expensive. There's one. Paramedics should get paid more, but they are less expensive. Another thing is that for Prosper, we have them. They're readily available. We've got them. They're right there. You can have their own transportation. So it works really well for us. And I think a lot of people don't realize that paramedics have the same training as RN. It's just different focus. So they're highly educated. They're incredibly intelligent. And for my money, our concern when we go out and do a community paramedic visit is, are we going to miss something? Are we going to miss a critical patient? They're not going to miss a critical patient. These guys are emergency and acutely ill patient specialists. That's what they do. They don't miss those kind of things because that's their training. So I've just seen over the years that they have really, they also, I think we can get, paramedics can get patients to say things to them and talk to them in a way that doctors can't. And I've seen it for years, over and over and over again, that they relate to patients in a different way. They're less intimidating. I think they think they're just more of a regular guy. And I think they really appreciate that. And they do a fabulous job relating to patients. So I'll skip through this. So we are not on grant anymore. We've been off grant for years. The hospital board decided to go ahead and continue to pay for the budget that we have. Really the only excess, we made a very streamlined process. We'll talk a lot about sustainability. I want to answer some of those questions for you because it costs money. And when we started our program, we had no idea what we were doing, I'll be honest with you. And it does not look much like it used to either. So for us, the only excess cost is me, which now I almost work myself out of a job. I'm a 0.1 with the GC program. I used to be 0.6, and I'm only down to a 0.1 because our paramedics are that stinking good. I'm just going to say they really are. They're fabulous. And also Epic. Epic, you know, it's really nice. It makes my life easy. So I'm down to a 0.1, and their cost is just running the rig. So it's not horribly expensive on our end because we're not that big. We're not that big. So these guys do no more than 3 treated paramedic visits a day. That's about what we can do without making them miserable and trying to make them run 911 calls and inter-facilities and CPP. It just gets a little too crazy. So if you're only looking at 3 a day, that's kind of our max. That works for us, and it makes them happy. And if they're happy, we're happy. How are we different? The main reason I see here is we're middle, right? And as far as the GCACH, we're here representing a little guy. I am so excited for what's going to be happening here in Tri-Cities and what we can do in these other areas, and I love watching the development. But it's a whole different story when you're talking about a town of 5,000 people. And so we are different. And a lot of our ACH that is different like that. And the hospital was not horribly expensive the way we do it because we have excess capacity. We don't have to hire extra people. They're not running 100 calls a day. So, you know, they've got some capacity there, and this makes them more efficient. And that makes our CEO very happy, which is a good thing. So the main thing that makes us different is we're little, and we're owned by a hospital district, so we're not a fire department. And that kind of changes the type of patients we see, because we do see our frequent fire super users, or whatever you want to call them. But we also see a lot of patients that are referred from our OD department, from surgery, from inpatient, and we get referrals from our clinics. We own 3 family practice clinics, and we get referrals from our clinic providers as well. And then, of course, all the little like pink sticky notes on my desk from EMS. So and there's all of those too. So that's a different kind of scope of type of patient. It's a little bit broader because we have the information. And that's been the biggest barrier I know to fire departments, that they don't have the information that we have. So we're on Epic, and as far as Epic concerned, we're a satellite of Cadillac, so we have lots of information available to us. And we've been doing this now for almost 7 years, and we've also developed a pretty extensive training program that our guys go through before they can do too many paramedic visits on their own, and we've trained a lot of other people in the region also. Why do we continue it? I know there's lots of people asking, why on earth? We're not getting paid for this, right? No, we all know we're not getting paid. Why on earth did they decide to keep it? One of it is our CEO at the time was Julie Peterson, who's now at Kittertat. She said it was the best community relations investment ever. Hands down. So she felt like that was well worth it, as well as I know our CFO was using the CP program and our data to help negotiate better reimbursement rates with their insurance. Because of our numbers, we can show that we've had better outcomes. And it does, people like it. They've already touched on the fact that it's a huge platform for referrals. We're referring to primary care doctors, to surgeons, to Meals on Wheels, to AGM long-term care. I don't know, you just name it. It's a great platform. These guys aren't out there trying to be mental health professionals. They're not out here trying to be a specialist that they are not, but they are able to identify needs and then get them in touch with people who can help. And like I already touched on, everybody loves to be paramedic. Sure, everyone does. So how does it work really quick? Most of us, a lot of us, we get referrals from Epic, an actual referral in the system that shows up in our work queue, and either myself or one of the medics on duty will review that one, make sure it's an appropriate one for us to see, because we're not going to Spokane to see patients. We're not going to try to say we have an area that they have to stay within. And then they will schedule that patient. They get to go through and look at their chart notes, their discharge instructions, whatever information they can gather on the patient. They go out to their home, they see them, and most home visits pretty much consist of a physical assessment, an environment assessment. They're doing medication reconciliation, they're doing teaching on medicine, they're identifying problems, just in general, kind of what you're doing at clinic, but you're doing it at home. And you know, one of our medics likes to write about their dogs and whatever pets and animals they have around, so get lots of information. And probably one of the most important things that happens is that these guys then put together a letter summarizing their visit, and that goes directly to the referring provider and the primary care physician, and that's direct contact with them. So we do all this kind of stuff. Yep, does it work? Yes, absolutely. We've got went through that. What we have found, because we've been doing it well enough with the federal grant, we've really had to do data. And just for West, I put data in here. So what we have found is that, and everyone knows this already, your super users are really, really hard to work with. We know that. We did not have a ton of success with them. They're hit and miss. There are some of them that you can identify a problem that is a fairly easy solution, and then there's some that have incredibly complex issues, or they just aren't going to, they're just going to do what they want. But we did find that we are incredibly effective with heart failure, pneumonia, COPD, diabetes, chest pain patients, and especially in that 50 to 75-year-old range, much more effective. And surgery patients are really a captive audience. Easy to find. They are very open to being seen, and surgeons love it. They actually love it a little too much. We have to say no, we can't see every patient. This is some data from when we were on the federal grant, and this is when we were here talking about how much reduction, we're talking about pre and post visit medical charges by age, and that's where you can see that middle group there that we actually really helped. So you have the younger group, which in general the reason why they're going to see the doctor is a completely different reason for the people in the middle. And we're in the middle, you're getting, now we're starting to get some of our more chronic issues. Maybe we have new diagnoses. And then we have our older group. Well, the problem with that group and our cohorts, when we were doing that, they kept dying on us. So that was a problem. But it's pretty well documented how expensive the last 6 months of life is. So that was something that kind of changed our focus. We had pretty good luck with these medical ones because these guys are really good counselors and really good at coaching and explaining things maybe in a way they didn't know before. Okay, busy slide, but this is pretty much the crux of our entire program. What we found by accident completely was that when these guys would go out and do a visit, they would actually make a patient, we had one that said, hey, I was going to call 911, go to the ER, but I knew you were going to be here at 2 o'clock, so I waited. So, like, ding, 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 ding. Hey, how much does an ambulance transport cost? How much does an ER visit cost? And the medic was able to call their doctor, get it situated, get things adjusted to where that patient did not go to the ER. And so we started tracking, so it was not part of our original plan, we did the program or anything. We started tracking what these guys were doing. What are you doing when you're there? And we started tracking it. How often are you calling the doctor and getting directions? How often are you calling and making a same-day appointment because you're worried about them and you want to see? And how often are you finding that medication errors, those mistakes or those problems? How often are you finding that? And we track. So we track that now. And what we did, this is busy. So that's what I'm doing here at the top. As you can see, so there's ones in red. Those are the ones that I consider direct correlation to avoiding healthcare charges. But I also track all the little stuff. So for last year, your estimated healthcare savings for 2018 from our community paramedic program was $617,000. We're just putting numbers to something we already know works. And it's pretty conservative. We're talking about, I know how much it costs for a transport within our area. I know how much an ER visit costs at Prosser. I know what percentage of patients are admitted at Prosser. I know this stuff because I've got the data. It's just numbers, it's just math. And really simple math, because nurses only do simple math. That's all we do. We solve for X and that's it. And so the number that they really like is the avoided healthcare charges per completed visit, $1,300. For every time they go see a patient, on average, $1,300 is not being spent. That's pretty amazing. And then I was so proud of them. I did these numbers and I sent them to Tyler a couple months ago. I go, oh my gosh, we're so cool. Look at this 30-day readmission rate for those hospitalized, 2%. That's unheard of. 30-day inpatient readmission rate of 2%. That is just, I was so excited. I was so proud of them. And I can't wait to tell you exactly how we got there. But we consistently have run 3.5, so that is 2.5 to 3.5 has been pretty common. So it was pretty excited for these numbers. I know it's a busy slide. We can ask questions on it in a minute. I just want to make sure I get through so you guys don't fall asleep and you're starving to death. So, okay, where's my little thing I'm pointing at? Okay. So to those in the EMS world, this whole thing of inpatient 30-day readmission rate, that is foreign, but this isn't. 55% reduction in ED visits, 6 months prior to our starting seeing them and 6 months after. And that's pretty consistent. The Palm Beach County has that number. And I heard that, a year and a half ago, someone was kind of talking about that. I go, I wonder what ours is. So I went back and they've been pretty consistent at that 50 to 60% reduction, 6 months on either side. So we have one patient that I'll give an example of, and his name is Michael. And Michael honestly was a pain in the butt. I took care of him in the ER. Not the nicest guy. Didn't really care for doctors, nurses, and honestly, he was incredibly sick. And he actually had terminal cancer, but he did not like to admit that. So I was running numbers, and I said this to Tyler a couple months ago when I was running our readmission rate. And I was running that 6 month either side report, and I went, I was so excited. So Michael, we worked hard with Michael. Michael loved, we have 2 paramedics that he particularly loved. And one of them would bring him milkshakes, and was not really his diabetic, but still. So I'm like, well, not the best thing, but usually the reason he was in the ER was for low sugar. So I'm like, okay. But he did really like the paramedic, and he didn't live that far from the hospital. He's right in town, so it's pretty easy to pop by and check in on him. And his family lives in Yakima, so they're by himself. So we saw him 9 times in 2018, and he had multiple. We can look here and see. I do this 6 months before. He had 4 EMS transports, 1 ER visit, and 6 inpatient admissions the 6 months prior to us really spending a lot of time with him. The 6 months after, he had 2, 2, and 2, a lot better. So I'm using the same numbers, the same ER visit. This is the average ER visit, the average ambulance, the average inpatient stay. So I didn't actually pull his numbers. I'm just using the general ones, just to put a number on it for fun. And I could not believe that they reduced his the expenses by $67,000. And what's really interesting is that he died in October. So this was the last 6 months of his life that they reduced him 63%. And we tried to get him into palliative care. We tried hospice. He didn't want any of that. He and cranky little guy. But he did get EMS over there at least 9 times. And then we got a fabulous phone call from his ex-wife and his son that were so appreciative of how much he would tell them how much he liked these guys because they would stop in and check. So it does work, and I know this whole sustainability thing is an issue, but we can talk a little bit more. Yes, there's some really good things here. We all told stories, and the stories are fabulous because it does work. Sustainability, we're talking about the fabulous work that's been done in Olympia. This is rolling out, supposed to, most recently, the updated timeline to roll out this Assess, Treat, and Refer program is now July 1st of this year. The way this works, it is based off Arizona's program, where you get a 911 call, you respond, you're like, you really don't need transport to the hospital. So you have some options. One option is they can use their entire county protocol. So they go out to an asthma patient, a known asthma patient. They're going out there. They can run their entire Benton County protocol on an asthma patient. I mean, giving them med treatment. You can give them polymedrol that's on your list. You can do all that stuff. Monitor them. They stabilize out. Great. You don't need to go to the ER. But how about we get you in to see your doctor? How about we get you set up to the urgent care? Or how about we refer you to our community paramedic program and they'll see you tomorrow? So previously that would be a no transport, right? Guys, you're not getting nothing. Well, the state's going to pay for that no transport now if you refer to one of those things. So now you get paid for that no transport, which, how much is that again?
Well, for the Medicaid, I think it's $115.
But then you get the YEMS too, or the Medicaid, you get the
for Medicare, it's a little bit more.
But for the YEMS one, you get more.
Yeah, I know.
Yeah, so you're going to get. Okay. Yeah. So they're going to get paid for that non-transport, but you don't get paid for the community paramedic visit. So you're sorry. There's a little bit of money coming in there. The other thing that's happening, which just Heather knows more about this, and it was mentioned by the chief of gentleman, is through CMS. You want to talk to them about this real quick? These are things to help with a little bit of sustainability. There is little bit of money. It's coming slowly. It's coming. It's coming slowly.
Thank you. So what she's referring to again is what I think it was Adam from Puget Sound was the ET3 model, which the applications for it again come out in also this summer, where to touch a little bit more on that is another way we can recover some of our monies, and that is we go out to the call, we treat the patient, we live in the home, we get to bill Medicare. These are Medicare patients for a BLS transport. But we also have to be in contact with a qualified healthcare practitioner, and then according to Medicare, that is an MD, a DO, PA, nurse practitioner, either on site with us or via telehealth. So, and that practitioner can get paid for that also through that telehealth, or if they're on site with us. So if you guys at District 4 happen to have your PA with you, then so be it. It works for you there. They're only awarding this to 40 providers and suppliers, and Medicare's definition of a provider and a supplier. Provider would be hospital-based ambulance service. Suppliers get to be like a fire department. So those kinds of things. We can also transport to these other destinations, much like what she was describing, clinics, where it's really helpful. We don't need to go to the ED. It reduces those ED visits. Maybe they have a swollen foot from whatever it happens to be, and they can go see their primary care doctor. We can take them there. That's pretty simple. So it's pretty interesting. The rollout is January 2020. So look for that. But that's something that we're all pretty interested in right now. So that about wraps up what we have.
I was just going to say, because I mentioned in my speech this morning, if you haven't already picked up on it, current Washington State law says we can only transport ED.
Exactly.
So it's not that we don't want to do or we can't. We literally cannot. Remember how we said back in the 70s, it was either transport to a hospital or a funeral home? Well, part of the reason why this law exists today is that people want to take people that aren't quite ready to do it.
For those in Cyberland, to reiterate what Eric was saying, was that basically state law of Washington does not allow us in the EMS and fire to transport you anywhere other than the emergency department. So that's why these new legislations are coming out, and what CMS is doing is super important, not only for us, giving us those options, but for our patients, giving them the options. According to this new ET3 model, they can still go to the ED if they want, and we transport it there. But we like to be able to give them the option instead of saying, which hospital do you want to go to? Would you rather go to this clinic or this clinic? Because it might be more appropriate for you, and it's going to save you money in the long run. So those are some ideas that is coming up. Any questions we can answer? Probably answer. All right, thank you guys very much.
And our last presenter for today before our panel discussion is Cameron Flynn, Spokane Ride to Care. Cameron serves as SNAP supervisor for several social determinants of health initiatives and a unique emergency diversion program. Spokane Ride to Care, she has an extensive experience in hospital administration, healthcare transportation, including ambulance services and program development in health and wellness industries, as well as social service agencies. She began her career as a care coordinator in a small rural hospital in the Appalachian Mountain region. My home. I'm also home here too. As a care coordinator at a small rural hospital, providing case management, care coordination for clients, she went on to work as a consultant and a life coach in a variety of areas throughout the United States, Ireland, and Africa. She obtained her Bachelor's of Arts in Business Administration from Gonzaga University and her Master's of Arts in Psychology from Antioch University in Seattle, Kansas. Welcome, Cameron.
All right, I stand before you interference with the lunch, so and the panel. So I'm here to talk about Spokane Ride to Care. It's a program that, and really this is going to be a real quick introduction. There's a lot of background information. Some of the folks in the room. Yeah, thank you. Is it better? Yeah, that's better. All right. So some of the folks in the room have heard about this program because my liaison with the fire department in Spokane has been over and talked with Richland and a variety of people. Mike Lopez. So Mike and I feel like I work for the fire department because I go there at least twice a week, and primarily for the work that we do around Spokane Ride to Care. But I represent a community action partner program, an agency, very large agency in Spokane, and it's called SNAP, Spokane Neighborhood Action Partners. And we got into this business because, of course, we have over 30 programs in the region of Spokane and throughout the eastern part of Washington. And we were asked by the mayor of the city to enter into a program to help reduce emergency department visits, and particularly with the low acuity folks. So the handout that I handed out before I came up here actually is a propaganda kind of material that I'm using. It's a promotion of just letting, we use this at our Better Health Together, ACH, and because the model program is fairly unique. There's a program very similar to this that did operate in King County, a very small angle of about 50 clients, and they ran some data. But in Reno, Nevada, in that region, there was a fairly large program, and it is still operating. And you can learn more about that by going to their website. But Spokane is unique enough that it's fairly large in its area in the county, it's rural, as well as the urban area of Spokane. We started with city have moved to the county region, including beginning to launch in some fire districts that are pretty rural. So kind of the same kind of dynamics and population that you would be seeing at your own ACH here. So I think that's why I was invited over to just kind of talk a little bit about what that program looks like, how we got started. So if we go to the next here, I do this myself. All right. So, you know, again, AAA, we've talked a lot about that, providing people the right level of care at the right time and by the appropriate healthcare resource. So that was our primary goal. We engaged over 20 members of our community to form a consortium that led the efforts of development, design, and implementation of this program beginning in 2016. And we launched in January of 2017 and have operated since. The first year of 2017, we had a pilot stage, and we had a third-party evaluator, Spokane Regional Health District, did our evaluation, and that upped our costs for that first year, but it was very valuable to have the knowledge that we got, particularly because we found that 61% was the cost reduction of this program. So, and they were able to access all kinds of data. I didn't bring that with me today, but so you are saved. If we could go to the video. I'm just going to show you this quick video. It's about 3 minutes, and it basically explains the program in its entirety. It was really well done. If you could. Oh, there you go. Okay. Thank you.
Really isn't in need of high-level emergency care. Somebody having non-violent symptoms, sore throat, non-strep abdominal pain. Obviously, early last year, those low acuity cases were transported to local emergency rooms because there were no other options available. We have always put people in the back of an ambulance and taken them to the hospital. In 2016, that old school way of dealing with 911 calls led to 10,000 ambulance rides to the ER, and later doctors determined a lot of them really weren't necessary. Those increasing number of calls for those situations actually overwhelm the emergency care system and take resources away from cardiac arrest, the strokes, the heart attacks. And that's why Spokane Valley Fire are now taking a new approach to their medical calls. A program called Spokane Ride to Care. Hey, partner, how you doing? So dial 911 and you'll still have EMTs and paramedics evaluating your injury or illness in a matter of minutes. But how and where you're taken for treatment could now be different. We'll provide, at no cost, a transportation from their residence or from the scene to the urgent care. MedStar Transportation has a contract to provide ride and care service to their territory vans or wheelchair accessible and equipped with fire extinguishers. Drivers like David Agnew know first aid, CPR, and are dispatched to calls at the fire department's request. Patients are taken to participating urgent care centers, but only if their symptoms don't warrant emergency treatments. Chest pain is cardiac related, even if it's minor. Strokes, any kind of major trauma, those people are not going to be referred into the program. Ideally. Okay, right? On the other hand, patients with non-urgent health problems can use the van to get to an urgent care facility where they're going to get treatment treatment and start feeling better a lot sooner. By getting somebody to an urgent care, they're going to get access to a physician or nurse practitioner faster than if they went to the emergency department and sat in the waiting room.
Oh, absolutely. You get the right, and you get the appropriate level of care, but at the same time, you also get time of care.
The Ride to Care van also picks up patients after they've been treated and takes them to participate in pharmacies to have their prescriptions filled. Spokane Neighborhood Action Partners, or SNAP, help find funding for Ride to Care and administers the program in the hopes of providing better medical treatments. So we're not denying care. What we're doing is trying to get them the right. So right care to the right person in the right setting at the right time. Experts say by letting paramedics triage 911 medical calls after they arrive on scene and then using Ride to Care when it's appropriate can save everyone time and money. Can we improve the healthcare experience for the individual, getting them better access to care faster, and then reducing the overall cost of the healthcare system? However, to make sure Ride to Care is meeting performance standards, staff has asked the Spokane Regional Health District to independently assess the program.
All right, so that kind of gives you a quick view of what, how the program actually operates. We have a third-party vendor that we engaged, a vendor out of Yakima, we put that out to an RFP to allow for, to assure that we had the right provider at the table. They have about 10 vans in the area in Spokane counties that helps us operate this program. So we basically are talking about, reducing the cost of ED services, and we set up a system of low income, or let me start again. We set up a system with urgent care clinics, 2 healthcare providers in the region, both Providence and CAS. They both have 2 urgent care clinics. The operation hours of this program is 8 a.m. to 8 p.m. We do that because that is the hours of the urgent care clinics. And, we mentioned earlier that there was 10,000 calls that were EMS medical. And then of that, during the core of the operation hours of the urgent care clinics, it went down to about 7,500 calls. So we have a lot of challenges in the, shall we say, the referral process of this program, because it is 911 activated, and we still, like some of you have already spoke, we still are dispatching the fire engines, we're still dispatching the ambulances, and the determination of Ride to Care is not done until at the scene. So we are working on a new program, or an expansion of this type of program, where we will continue to take the 911 calls and receive referrals from the 911, but we are also looking at nurse lines to do that direct referral so that we are saving even more money. That's in the process right now. We are also working with the fire department and weekly. The reason that I go to the clinic, to the fire department weekly, is we actually review each of the cases clinically for quality assurance to assure that that client has arrived at the right place at the right location, right? So we sometimes determine that that referral may not have been the appropriate referral, and then we're getting back to the paramedics, we're getting back to the EMS system to say, let's review this case in more detail and make the appropriate referral. We had a lot of, the first year, there was a lot of those errors made. There were probably 100 calls that were probably not appropriately routed. We've now reduced that tremendously to almost, it's down to 3% of our calls now. So they're still, they're not good historians at the site. There's lots of reasons. We have a 400-page protocols that the paramedics have to remember. There's there's a lot of processes through this. My PowerPoint presentation, which I understand will be posted, has a lot of the information about the protocols and the processes. I am going to go to a couple of things that I think that might be really important for me to talk about right this moment, just because I think financially people are really would be want to know how we funded this program. So I'm just going to go there really fast, and then again, all these slides will be on your site, right? All right. So when we formed our coalition, we asked for the managed care organization to join the coalition, as well as we had several private foundations, and the city of Spokane, of course, was very invested in the outcome of this program. So we got a lot of funding from all of those individuals, or entities, should I say. We also got money from the Department of Commerce, because CAP agencies are funded through the Department of Commerce, and we set aside a bucket of money for this program. We also have money from the Washington State Department of Transportation, and we were able to do some funding through the 5310 contracts at our local transit authority. So just giving you some ideas about future partnerships and collaborations. The other thing we did was we went back to Healthcare Authority to ask if there was any way that we could get reimbursed for the rides themselves. And what we were able to do was to work through our regional Medicaid broker and the Healthcare Authority, and then as well as our vendor, our vendor, to make a determination that each ride would be a fee that we would pay, we as SNAP would pay, and we wanted to get reimbursed for the Medicaid rides, which we did. We were very fortunate that MedStar actually charges us $35 for each ride to, and then $35 from. And if it's wheelchair, it's a little bit more. It's over a certain amount of mileage, so it's more. But the Healthcare Authority stepped in and said, yes, we'll reimburse you at the $35. So the amount of people that the clientele of the target population has been 75% of them have been Medicaid users. And so 75% of the cost of the ride has been reimbursed. So through the evaluation, we determined, third-party evaluation, we determined that there was some streamlining process that we could do to lower the cost of the actual operation of the program. And like Carla had mentioned, I'm now like 0.1 to the Spokane Ride Care program, because what we did was we as an agency made a determination that transportation was a huge gap in our community, and we decided to work in partnership with our other agencies and with our Better Health Together, GCACH, and determine that a social determinant of health program is the way to go. And so we have, I manage 6 different initiatives now where I do a lot of sending a community health worker into their homes. We work with CHAZ, we have a large contract with CHAZ in Spokane to be able to say, we send a community health worker into their homes and do in-home assessments, and then we provide transportation to and from. Medical services, GCACH services. So there was a way for us to streamline our processes, and we think that we'll even be even more streamlined when we're able to get to the nurse line referrals or another medical professional referral process. So, I'm going to end there because I know lunch and panel. So, question.
So like it's a success in Spokane. Do you think in a smaller, rural environment, this type of an arrangement could possibly work?
It is the resources that it takes to do some of that. One is your alternative destination, right? So how close is an alternative destination? That's one of the factors. The other is the volume of that. You know, you're going to have some operational pieces, and will it work? I will tell you that we're still averaging just 1.5 per day calls. There's days that we have 10. There's days we have none. So we have a lot of challenges. I think you might have the same challenges in the sense of the society, there's the population in which we're serving, they believe, they traditionally, culturally have received their health care through emergency departments. There's some efforts on our part working with our managed care organizations to do education to the population so that we can begin to educate the benefits of urgent care versus an emergency department. So that's all in the works as well. But to answer your question, I think there's a lot of factors that we would have to look at. Thank you.
So you said that you have the community health workers, are they paid workers? And if they are, how is that funded?
Yeah, so to take the CHAS contract, the CHAS contract is a vendor service that they are engaging us with, and they are paid, our community health workers, and it's a per unit, a 15-minute increment fee that we have. And CHAS has that money set aside because they were spending that much money, or this much money, on their transportation, getting people to and from their clinics. So they took that money from that fund and moved it over to us. And there's greater benefits. They're not only getting transportation, but they're getting food. Yeah.
Unfortunately, we ran out of time for the panel discussion. I want to be respectful of everyone's time. I know that everybody's really busy. If I could ask that the speakers stay around for a little bit in case there's questions, I would greatly appreciate that. And thank you all for coming. There's also a draft curriculum, educational curriculum, that is included in this packet as well for additional training. Thank you, guys.